So, ladies and gentlemen, on behalf of ImagingBiz.com and Intelerad, I'd like to welcome you to a webcast entitled Radiology Productivity in Action, a testimonial from the reading room. If you have questions at any time during the presentation, you may type your questions in the Q&A box located at the bottom of the interface below the presentation. Questions will be collected and answered accordingly at the end of the presentation. If you are in need of technical assistance, please dial 1-800-303-0442 and reference confirmation number 325-73140. This information is also listed on your confirmation email. Please note that this conference is being recorded. And now it's my pleasure to turn the call over to Curtis Pickel.
Thank you very much, and welcome to everyone around the country. Thank you for taking the time to join us this morning. I'm the publisher of the Radiology Business Journal and Imaging Biz, and we, our mission, as you know, is to bring information to radiology groups and practices around the country that are grappling with these very complex issues about how to not only survive but thrive in a difficult era. So we put together a webinar today that's going to feature a very interesting case study on success. And with that in mind, I wanted to just kind of review very quickly with you a bit of an introduction and talk about the context for today's discussion and how we're going to essentially set the model in place so that leaders in medical imaging services will have a better understanding of how they can leverage their technologies for success in this difficult time. The other thing is that we want to build a framework for an understanding of how to find solutions within the practice itself, give us some perspective on not only the issues but the trends facing radiology practices around the country, and then finally review a little bit about the state of the medical imaging marketplace, what I call a marketplace, and identify that which best exemplifies the value proposition that we have in radiology. So to that end, let's just kind of take a few minutes and think about the context that we're all working within. I characterize it as radiology's perfect storm. That essentially is kind of the threat assessment snapshot that I've outlined for you here. Now, this isn't all just meant to be doom and gloom, but it is kind of meant to essentially put together for you the convergence of these issues and trends in a way that builds an understanding of how the headwinds are moving in directions that I think in many respects are causing confusion and certainly a lot of anxiety. But within this context, we can identify some success factors and identify ways that you can thrive within this environment. So think about the fact that we are faced with increased payer scrutiny. No question about it that the competition has become hyperactive. On top of that, the obvious declining reimbursement and diminishing resources. I mean, think about the things that characterize your daily practice of radiology in this environment. Identifying what is an ACO and how do you play with the ACOs. Understanding the mandates from CMS and others that pay for performance will be a major model going forward. Price and quality transparency, a host of these things that really, again, kind of converge to create an environment where you're going to be asked to do more with less. Think about the mandate, for example, of Obamacare and combined with the 78 million baby boomers who are just now coming of age where they will be entering the healthcare arena. So this is kind of our context that creates a picture of this perfect storm that we're all trying to deal with. Within that, we need to now think about more than ever how we can break out of our functional silos that typically exist within the hospital setting, within the radiology practice setting, within the imaging center setting, get an understanding of how to weave through a thread through these silos and link the clinical, physician, ops, marketing and business development, certainly the physician communities, understand how we need to be aligned and all on the same page and rowing in the same direction to face these headwinds in ways that will allow us to create success models. Overlay on top of that what Regina Hertzlinger, the health economist at Harvard, identifies as kind of the new consumer-driven healthcare model, where increasingly your patients and the other stakeholders are going to be working within an environment where they expect choice. They will be empowered. They will definitely be involved. It's going to create this sort of radical change in the way we do business. So I think, summarizing this perfect storm, success in this environment will be increasingly dependent upon how we focus our attention, the absolute precision with which we execute our strategies and tactics, how we articulate and animate and live out those brand value propositions that we have as practitioners, how we can develop platinum levels of customer service, and within that, as a good business prospect, understand and leverage workflow, management, productivity, and above all, how we measure those. I characterize the radiology market as a market. It lives and breathes as any other traditional marketplace would, and we are working within a market environment that is maturing. And along with that maturation, we have at least three and perhaps others that are sort of distinct characteristics of a mature marketplace. And we're seeing it all around us. Consolidation, where payers and providers are creating new alliances, the erosion of profit margins and consolidation. So within that, we need to find ways to reinvent ourselves before it is demanded of us. And a part of that reinvention is to look within the practice to identify those levers of efficiency and productivity that can allow us to function well within a mature marketplace and to succeed. Not only the framework, but an understanding of how we can review where we fit in this, the business of radiology. I think that today's and tomorrow's practices will succeed or fail depending on their ability to understand analytics and productivity tools. But beyond that, to be able to kind of make actionable intelligence out of those data, and how to work within an environment where informatics and analytics and metrics and business intelligence and RVU benchmarks kind of combine to help us work through those expectations that the payers and the other stakeholders have. Among them is decision support software and other kinds of systems that will allow us not only to better manage utilization, but to work more efficiently within the practice. So template-based reporting is one of the things we're going to talk about this morning, and that kind of fits nicely within this expectation model that the payers have of quality, cost, outcomes, and productivity. So within that, then I want to kind of have you think about how the organization itself needs to be aligned around this paradigm via constant communication and buy-in. How we live our branding proposition and how we empower ambassadors within the practice, how we animate that kind of purpose that we have and leverage our technologies in new and interesting ways. And also, a side benefit is to align our physician partners around some new and realistic benchmarks so that we can get beyond kind of the sort of cultural transformation issues related to workflow and productivity, and have it be seen within the practice as a standard business metric, just like any other business metric. And in doing so, I think we can develop a model where we have achievement-oriented goals. The leadership is, empowered to kind of take the practice to the next level, and essentially and ultimately create a role model organization, as we're going to see this morning, a good example of that. So those are the kind of the background issues that I wanted you to have at your fingertips as we review a fascinating case study, where workflow, structured reporting, and productivity kind of combine to not only increase profitability, but in an interesting way look at how your practice can expand its market share and align all the stakeholders within the organization, as we talked about the need to kind of link those functional silos. So we're going to hear from Dr. Cheryl Jordan, who is the breast imaging and interventional specialist at Carolina Regional Radiology. It's in a market with consistently declining revenues in the imaging center space, as we know, from around the country, and their market is no different. But Dr. Jordan and her colleagues have found ways to kind of leverage technology and create innovation within the practice in ways that are unique and interesting. We will open it up for questions after Dr. Jordan's presentation, and at this point I'm going to turn it over to her and take it away, Dr. Jordan.
Okay, thank you, Mr. Pickel. Want to say good afternoon to all of you. I've actually reviewed the participant list, and so it's good morning to some of you. Participant list is an august group. There's an august group of you on the line, and I wanted to thank you for your interest, to thank you for your participation. I'm sure Mr. Pickel and Intelerad joined me in saying that. My goal, actually our goal today, is to make this time as efficient and as effective as it possibly can be for you. We'll get through my slides, and then we'll open it up for questions. We welcome them. Okay. As Mr. Pickel said, I'm actually breast imager and interventionalist at Carolina Regional Radiology. I'm also, actually, you'll notice, in addition to being an MD, I'm an RCC. So I'm actually a RCM. I'm a revenue cycle management aficionado as well. And therein lies some of my interest and my abilities in this arena. Carolina Regional Radiology is a full-service imaging and interventional radiology practice. 22, actually now 23. We just added a generalist. Board-certified radiologists who perform 500,000 exams annually for hospitals, imaging centers, physician practices, and clinics in a 10-county region, much of which is rural, I might add, in southeastern North Carolina. These are two of our imaging centers on the left. Valley Regional Imaging is a joint venture, and Carolina Regional Radiology, the bottom picture, is a wholly owned clinic. And on the right hand, we have our resident propeller head. Dr. Emerides is the president and managing partner of our group. He is considerably younger than I am. I dictated my first case in 1984. Dr. Emerides is considerably younger and a whole lot smarter. He has managed to get himself fully trained in MR, MSK, breast, and IT in Pittsburgh. He's a big guy, and he's worth more than his weight in gold, so he is our propeller head. And we have him to thank, along with Intelerad, for many of these what have turned out to be extraordinarily smart decisions. CRR has sustained same-shop growth annually of 25% at each of 3 outpatient centers. We are currently sustaining our month-over-month procedure gains that are the highest ever. And here's an astonishing statistic. Our 2010 to 2012 growth in mammography business and its adjuncts is 126%. That is actually because of, in no small part, facilitated by our technology as a key driver. It is no surprise that Intelerad approached CRR as a case study after they've watched with vested interest our success story, and this is part of it. In 2009, Dr. Emerides and other principals at CRR reviewed the leading radiology software solutions. We needed a solution to integrate multiple modalities from several different locations. In that 10-county radius, we, at that point, served four hospitals, multiple physician practices, and our own imaging centers. In 2010, we selected IntelliPax and initiated the use of IntelliOne, which is the unified reading solution that we are currently on and hope to even greater expand. The decisions were made because of the key factors of product capabilities and the integration with other radiology software, and the team had a long-term strategy in mind, and that long-term strategy was unifying our workflow and driving efficiency. Previously, simply put, we were using too many vendors at too many different facilities. The radiologists among us can feel our pain, can feel my pain. The amount of logins was astronomical on call. Just the amount of logins and passwords we needed to remember as individuals was astonishing, particularly the part where they were seeming to change every 3 months. The embedded nature of the VR module was a key advantage over the others that we looked at that required them to run separately alongside PACS. The goal for the CRO radiologist is to only need to learn one intuitive interface to eliminate the need to switch between different systems for different facilities. And then after Intelerad and IntelliOne came MMR, Intelerad's dictation module with VR and structured reporting, and that certainly has enabled us to achieve the single streamlined interface and workflow. In 2011, when it first became available, or I think Intelerad can speak to this, but soon after it first became available, we actually deployed the module as one of the first sites. Again, it's a single streamlined interface and workflow, and I was asked to speak today, I think, because of all of the radiologists and all of the modalities. I'm probably the one that embraced it, in fact, insisted upon it the soonest. What has happened with our breast imaging program, our breast clinics, is that the use of MMR and the use of structured reporting, so-called template-based reporting, has reduced our turnaround time from literally minutes, from days to literally minutes. We'll speak to this over and over again. The breast imaging templates are clear, compliant with ACR, MQSA, CMS. They're correct, they're concise, they're quick, and the turnaround time has been dramatically reduced. The thought at the facility, the party line at all of our facilities actually, but certainly our flagship outpatient facility, VRI, is that the breast program the breast clinic has actually led the charge to clinic success, to improved procedure volumes, and certainly been the key revenue driver. We're going to switch and speak for a few moments. This is what the bulk, honestly, the focus of my discussion will be until we open it up to questions. This is the topic that generates the most interest. I give a talk at North Carolina ACR meeting entitled Assessing Margins in Breast Imaging / Operating, that is. I come at it from an RCM slant. And over the course of the 3-year time frame that I've given it / prepared it, what has happened is that the part of the talk that has generated by far the most interest, because the participants in the course are radiologists largely. There are technologists and there are a few business people that attend, but it's largely radiologists. The topic, the slides that have generated the most interest is the structured reporting, and there's always a rush to the podium to ask about CRR's specific reporting. And honestly, we've been able to accomplish all of that because of MMR and Intelerad. The structured reporting points to be made. The turnaround time is exemplary. I'll amplify on each of these in ensuing slides. The ACR has basically made it easy for breast imagers, at least, because they've insisted upon it with BI-RADS. The structured reports are BI-RADS compliant. Furthermore, the structured reports has actually had the intended and even to some degree unintended effect of guiding the radiologist, guides the technologist, certainly guides the clinicians. Something near and dear to me, they are all coding and billing optimized, which is different than an additional overlay than the typical BI-RADS reporting. And they are CMS report signature compliant. We'll discuss that latter point as well in just a little bit. Improved turnaround time, literally minutes. ACR BI-RADS compliant. The reports for the breast imaging that we use, that we developed, are based on ACR BI-RADS manual, and they therefore include the use of the ACR lexicon. They include the BI-RADS report organization, and they, of course, include categories 0 through 6, which we're all mandated to do. The utilization of BI-RADS as the foundation has actually provided the framework for radiologists to guide review and interpretations of patient studies. The original BI-RADS committee, which was back in the 1980s, would be so proud of us, actually, because, of course, that's what they intended for the radiologists on the line, and for the other breast imagers and the clinic directors and the participants with those monikers. ACR BI-RADS intended for us to respond this way, but it's amazing and a little surprising to me how the templates end up being the foundation, being the framework. They assist you in interpretation of the images. They assist you in direction of your attention toward the images, and honestly, they prevent you from falling victim to your own, when left to your own devices. You're using BI-RADS compliant lingo, and therefore you're reviewing the images inside the context of that. In case in point, you're looking for masses, calcifications, and sites of architectural distortion. The standardization further enhances the technologist's understanding for additional views and surveillance accelerated follow-up. It's improving the technologist skills each of our ladies has learned inside these structured reports, inside these templates. And importantly, to those of us who are trying to run efficient, effective reading rooms, the use of the standardization has reduced the need for radiologist interruptions. I very infrequently now have a technologist who has to come in and ask me what one of my colleagues was saying, or even worse, what I was trying to say. There's been a dramatic improvement in that. That's a big plus. Here. The standardization enhances our referring physician's understanding. We know that already about BI-RADS. It's the reason the original BI-RADS committee even existed. Remember, American College of Surgeons, American College of Radiology got together and said we need to make these reports sensible. That was in the 80s and 90s. But we've taken it, we were able to, with Intelerad help, take it many, many steps further. We vetted these through our top referring physicians anyway, and so we know the reports are to their liking. We know that they like knowing where to look for what they need to know. The reports are our 5 C's, as we call them: clear, concise, consistent, compliant, and there is a C in quick. The reports are optimized for coding and billing, and as you know, as the business folks out there know, the coverage is based on local coverage determinants for many modalities. The Obamacare, interestingly, and its adjuncts has been highly desirable for breast imaging. Once a lowly diagnostic component of radiology, breast imaging is anything but now. I'm sure many of you know that it's number one supply-demand mismatch in terms of radiology, breast imagers, women's imagers. It has the, at least for our practice and for many practices with whom I've had candid discussions, it has the highest payment per work RVU. And that is actually because of the advantages in the business arena for screening mammography. So it makes perfect sense that anything you can do to optimize billing, optimize coding and therefore billing in breast imaging is going to optimize your practices, your facilities' revenue cycle management. Furthermore, the use of structured reporting adheres to the CMS report signature mandate. I'm going to digress only for a second here and discuss this, but for many of us who are doing high-volume screening programs for years and years, we are actually either checking a box or verbally instructing a reading room assistant to check a box, and then the reports are subsequently entered. They may or may not be signature reviewed by the radiologist. Our belief on the part of our billing company, on the part of our current of our practice administration, and on the part of council review, is that unless the radiologist actually signature signs that screening report, it probably is not. In fact, not probably. It is not adhering to the CMS report signature mandate, and certainly would not pass in an audit setting. So. Structured reporting and MMR, our existing methodology, adheres to the CMS report signature mandate, which has been highly desirable, on the, at least on the part of the billing and compliance. The templates were created by a university fellowship trained breast imager who had reinvented herself. I know. Mr. Paquel was addressing reinvention and how practices need to reinvent themselves. And so in the early 2000s, I did revenue cycle management and coding, all the while practicing as a general radiologist doing women's imaging. And then in 2010, when my youngest son went to college, Mom went to college too, and I actually did a dedicated breast fellowship. And so brought back to the private sector the many good things about academics, and was able to actually template, mirror some of the institution's hospital reporting, so we know there's a universality of this. This is not something that is community unique by any stretch of the imagination. Our structured reporting in Intelerad, we use multimodality reporting. We have segregated breast templates. We have 28 total breast macros. This is exactly the slide that generates so much interest / enthusiasm / comment at the ACR meetings. The reports are, through MMR, are auto-faxed to the referring MD when the reports are signed, again, by the interpreting radiologist. The morning screening patients receive their normal letter or their callback abnormal letter in next day's mail. And the afternoon screening patients receive their letter. We're at the mercy of the U.S. Postal Service. They receive their letter in 2-day mail. The diagnostic patients, reports are in the physician's offices before the ladies leave our facility. Ladies, and we have an occasional gent, of course, leave the facility. By the time we, as older ladies and even younger ladies, get ourselves reassembled and redressed, and we've patted our hair and we've tucked in our shirts, because of the use of structured reporting, I, as the interpreting radiologist, have already actually dropped in the particulars that I need to on the templates, and I have clicked sign. So it has obviated the need to interact as much with the referring physician's offices. It actually has obviated the need, at least in the longer term here, to interact as directly with the physicians. I'll show some sample breast templates. You'll cue in, I hope you are if you're listening well, you'll cue in on the comment I just made about decreasing the physician-to-physician interaction. It's not that the peer-to-peer interaction is decreased, quite the contrary. This is past, as one of my sons has always said, past mustard. It's past muster of our top referring physicians. Many of them do prefer to be called, but certainly most of them do not prefer to be dragged out of a clinic office, a clinic visit, out of a patient's room to have an abnormal mammogram result discussed. And so the way we have over time evolved is that we are able to generate the reports immediately. We contact the office. I have assistants that do this. Of course, I don't do this. We contact the office and alert them to the report on their fax machine, and the nurses / physician extenders / office staff, depending on which individual office we're talking about, know to give the report to the physician, and then he or she calls me back or calls the additional breast imagers back if there are concerns in the beginning or any questions. In the beginning, of course, there was far more interaction in the beginning, but there just simply doesn't seem to need to be any longer, and that is an advantage, not a disadvantage, as it turns out, for our practice. Our segregated breast templates, I've already told you that we have 28 total breast macros. It may seem astonishing to be able to do 100 work RVUs a day inside of 28 total breast macros, but that's exactly what we accomplished. We have 10 screening macros. We have 10 diagnostic macros. We have only one diagnostic breast ultrasound macro. We don't do whole breast screening at in our practice as yet. So we have one diagnostic breast ultrasound. We have 2 breast MRs. We have a negative, and we have a positive one. We have 4 breast IRs for the procedures, the interventional procedures that we do. We have 1 breast nuclear medicine. We do not do molecular imaging, not much to speak of. We do an occasional scintillammography when I know that there are many of you who will cringe at that. But the breast nuclear medicine template that is particularly helpful is the sentinel node injection. I can't tell you how that streamlines care delivery, because basically you're literally left to saying write 2:53, 2:63, 11:14 a.m. And at the end of that, you have a superb nuclear medicine sentinel node injection report that is free of typos, has included everything that needs to be included to be coded successfully, and is already in the referring physician's office in a highly desirable RCM modality, i.e. nuclear medicine, where where many of us are losing market share, I might add. So it's nice to be gaining market share in nuclear medicine. I told you I was going to show a few samples, and here are a few of them. Just by way of example, there's only on this screening, this is a scattered fibroglobulin densities, one of the screenings, there is a need to say 1 or 2 words, and that is to fill in the comparisons. And I want to alert you or direct your attention toward the technique part. It includes computer-aided detection, which is a separate billable CPT code that is, for many of us, still well reimbursed. And there's no ability to be left to your own devices when you're using these structured reporting and to forget to say CAD. That's a common mistake among radiologists in their own reports. Just gets lost in the shuffle of what all needs to be said for the technique. Here's an example of a diagnostic callback. And there's a need to add a few more in. It's remarkable how quickly, especially with the use of the handset and the standard programming of the buttons, that seems to be fairly universal at UNC. The buttons did exactly the same thing. So buttonology has not turned out to be that difficult. Honestly, it's turning out to be fairly standard. Use the buttons and you just flip through these individual fields and fill them in. And again, these are reports, these negative callback screening mammograms, these diagnostic mammograms that take a surprising toll on radiologists as we are reading them. So it's nice to have that shortened for us, that process shortened for us. Oh, sorry about that. And then here's a nice example of how the use of a macro makes us far more efficient as radiologists. This is a template, a structured report for ultrasound-guided core needle biopsy and clip placement. Depending on whether you do the diagnostic mammogram or not, this amounts to as many as 6 or 7 CPT codes. And you can only imagine that as a radiologist, particularly a busy radiologist, it's easy to leave out some of the particular needed vernacular for all those CPT codes to be successfully coded. I'll tell you, as a coder, I don't actually code actively. I have a tremendous amount of respect for those men and women that do, but I don't code actively. But what I can tell you, I understand well the rules by which they exist, the rules they have to play inside. And if we don't say it, if it's not in the written word, if it's not in the so-called radiology charge, which is what the report is called, it's called the radiology charge in RCM vernacular, then a coder cannot and should not, and probably now will not, code. So if you don't say that ICAD was rendered, you're out that extra CPT code. If you don't say that the metallic localizer clip was placed under ultrasound guidance, you can't code, and you can't expect payment for both the ultrasound component and the clip placement. If you don't say that the vacuum-assisted technique was used for a stereotactic core needle biopsy, you can't expect yourself to be anything other than downcoded from a vacuum-assisted core needle biopsy to a non-vacuum-assisted biopsy. So this is remarkable. Now, the radiologists among us will have particular interest in this. This is one of the slides that always piques discussion. But you have, in this one, you have 3 fields to fill in. And, 3 fields to fill in, and the physician's name. So 4 fields, 5 fields. In the impression there's a right or left, and it's okay to leave that one out, actually. You set it up above. And your 6 or 7 CPT codes, again, in a specialty that doesn't require pre-auth, doesn't require pre-certs, doesn't require much vigilance on the part of your RCM specialists, and hardly ever, honestly, requires any sort of denial or claims adjudication efforts on your part. Compared to the national benchmarks of 65 work RVUs per radiologist, this is from the RVMA database, CRR radiologists average somewhere between 78 and 79, upwards of 80 per month. In the breast imaging program across our practice, I'm embarrassed to admit actually what it was when we first started. I had come from academics, and it is what it is. So I was slow in the beginning, or slow for me, that's for sure. In part, it was because you'll see in the 3rd bullet point, the breast imagers are speaking with the patients. We're speaking with the patients frequently, even with their family members. We're building that referral base with referring physicians, sort of building the clinic, as it were. That's another thing I wasn't certain that I would remember to say that, so I want to emphasize that. We no longer call it the facility. We no longer call it the department. We actually call it a clinic. And the communities call it a clinic. And and the patients think of it as a clinic. And that's been it's been important in our branding. It's been important in our community effort. So anyway, back to this. The clinic requires phone calls to the referring physicians, and of course, managing the byproducts of a successful screening program requires that you actually do breast interventional procedures, which take you out of your reading room, takes you off your hamster wheel of interpretation. And so the work RVUs were down, again, I'm embarrassed to even admit this, but down in the 50s daily. In the early parts of the clinic, and we had a year-over-year increase to 85.2 is breast imaging average work RVU, and most recently, again, one of these things I'm embarrassed to admit, I discovered the auto load button in Intelerad, and so once the auto load button for some of the work lists was made known to me, or I stumbled upon it, the daily work RVUs now are closer to 100. They're varying between 96 and occasionally I'm peaking 100. It's no surprise that as we have improved our services through all the efforts and the specific bullet points that we discussed earlier, it's no surprise that actually we've seen further increase in business. We've without question, technology has been a key driver, perhaps, actually probably the key driver. I'm not going to say that the personalities involved. I'm not going to say that the community contacts involved. I'm not going to say that the long existing relationship that CRR has had in the community. We've actually been in the community for 54 years now, 54 or 55 years in different names. We were Fayetteville X-Ray Associates to begin with, but we've been Carolina Regional Radiology for quite some time now. I'm not going to say that those haven't contributed? Because of course they have. And of course the energy and the enthusiasm and the desire to, the need actually, coupled with desire, to pull off all of those things that Curtis listed that we needed to do to be successful. I'm not going to tell you that all those things haven't contributed. Of course they have, but technology's been probably the key driver. It's gained the attention of the physician and patient community. We actually have captured market share from competitors. We have been successful in managing the byproducts of a vigorous screening program. What comes out of a vigorous screening mammography program, which itself has the highest payment per work RVU of any modality, and will continue to because of Obamacare, interestingly, there is a necessary set of byproducts, and those byproducts spinning off of screening are diagnostic mammography, ultrasound, breast MRI, the procedures, and so actually we've achieved success in managing those byproducts successfully. There we go. We are offering turnkey care from screening mammography to diagnostic workup to biopsy to needle loc and sentinel node injection. What has happened, we're actually in a competitive environment here. The breast surgeons do interventional procedures in our community, and instead of actually continuing to compete, we actually now have seen a steady stream of direct referrals. We have really only one remaining breast surgeon that does any ultrasound core needle biopsy work himself, and all the rest of the breast surgeons just send to us now. The patients are asking it, and the care has been telescoped dramatically. The episode of care is dramatically telescoped in terms of the turnaround time, not only on the reporting but on the procedure, actually. So that's it's much easier for the breast surgeons to send the patients to us and have the biopsy done and the pathology results in hand when they see the patient in follow-up 2.5 or 3 days later than to actually, from their diagnostic clinic, try to even schedule the ultrasound-guided procedures at our local hospital. Just the reality of inpatient/outpatient hospital care for our facility, for our community. We've also had steerage of pre-op breast cancer patients to the nearby outpatient surgery center by our breast surgeons. Not all of them, but certainly the largest group in town actually sends their patients now to the outpatient surgery center, which is across the street, and that's been good, as you can imagine, for our needle localization, but our nuclear medicine program, our sentinel node injections, it's been good. It has, for our facility, necessitated the addition of a second digital mammo unit and the addition of a breast coil. We actually only had one breast coil for our community, and it was at our hospital site, our hospital partner. But we've added a breast coil for our facility. The VRI breast program is credited for the facility's success. What happened actually is that the breast program and the clinic, which is now just called the clinic actually has piqued our referring physicians' interest. Again, our patient population are big supporters, hearty supporters. And I think unlike labor and delivery suites, which there was a trend, I really am showing my age over and over again through this discussion, as in I've worked on 30 different operating systems, if you can believe that, since 1984. I sat down with Dr. Merides and I tallied all the different places I'd worked and all the different logins and passwords at different facilities. I'm showing my age with some of this, but I certainly remember the trend when labor and delivery suites were upfitted, and somehow, because women were the healthcare dollar drivers for their families, how that was going to somehow change everything. And I understand more recently, and Mr. Battelle can probably speak to this far better than I can. I understand that didn't actually pan out nearly as much as there wasn't as much of a ROI. There wasn't a return on investment for that as they might have hoped/expected. And so what we have seen, believe it or not, finally the women are making all the decisions, because actually The success of our report turnaround time, the success of our patient high satisfaction surveys has basically made our facilities the paths of least resistance in terms of scheduling and the desired providers. And so this was an old, talk about having gotten yourself in a hole. We were a Health South facility, if you can believe this VRI place. It was an old Health South facility. So in 2009, we when they put on orange suits and went off to day programs, we regained control of our local facility, our outpatient facility here in Fayetteville, at least. We've had control of the others for years, of course. But in January 2012, again, with technology as a key driver, we, for the first time, achieved our daily procedure and revenue goals, and we have experienced record 2012 month-over-month gains since. We are not only is breast imaging flourishing, but probably more importantly or as importantly for the bottom line, our MR, CT high-end imaging business is doing that, flourishing and becoming a key financial driver. It's nice to be well ahead of the curve, I think, and not be on the bleeding edge, but rather on the cutting edge. Many of you will know that the ACR Bulletin March 2012 actually referenced structured reporting. I know for a fact that our local academic institutions are very interested to pursue and to pursue more in other modalities. Winston-Salem, Bowman Gray, well, actually, that is my age. I am showing my age. It was called Bowman Gray for years and years. It's now called Wake Forest School of Medicine. Is quoted. She says there's a lot of interest in developing standardized reporting systems. They would use the same format and language, be produced quickly, yield data that's easily coded or mined for clinical, administrative, or research purposes, and that's precisely what we've done. The ACR has been getting more and more into the business. There's a liver reporting system now. That's called LIRADS, and this is just going to be, I'm confident, the tip of the iceberg, based with discussions I've been having at the academic institutions. Okay, finishing up, and I can't thank you enough. Any questions?
Great, thank you so much, Dr. Jordan. I think that was a great review of the elements that I think that I have seen and talked about and written about these past couple of years about how an organization with effective leadership, and obviously Dr. Emerides has provided some pretty effective leadership for you all. It sounds like you have a great environment in which innovation thrives, and alignment of everybody within the organization to create this kind of success model. And you have, I think in very interesting ways, leveraged your technology to the max. And I'm kind of intrigued about the fact that the passion that you obviously exhibit for what you do, I would assume is kind of inculcated throughout the organization so that others kind of embrace that same passion and quest for service and quality. So it comes across really nicely. Thank you so much for sharing that with us. We do have time for some questions, and I have a few that the audience has submitted. The first thing I'd like to say is that someone had asked about the fact, is this going to be available? Is this presentation going to be available? And yes, it will be on our website, imagingbiz.com, and it will also be available on Intelerad website. So I think within 48 hours or so, the recording will be posted. So those of you who wanted to kind of see a little bit more of it will have a chance to do that. Dr. Jordan, the use of the question is, do you have any plans for TOMO at this point? Are there any plans for kind of introducing that within the practice, or have you already?
Yes, we actually we've just now introduced it in one of our southern counties, and so we will not introduce it for the foreseeable future in our local Fayetteville community, but we will use our the decision of one of our hospital sites, our hospital affiliates in Columbus County, we will use that as our test case, as it were. So we do, in fact, have a TOMO unit, and TOMO actually runs the women's imaging packages, I understand, and Jonathan and the others from Intelerad can speak up, but I understand Intelerad has the capability of using TOMO. I will say from an RCM perspective, at least right now, it's not overly advantageous. I realize we're in the business of practicing good medicine, and there's certainly patients population that it seems to have potential benefit from TOMO. It just is not as clearly defined medically yet, and so therefore it's not as clearly defined in the business models yet. But we absolutely do it, and Intelerad can support it, as I understand. Again, Jonathan can speak to that.
Yeah, that's correct. We're actually in the process of finishing the development right now. So we expect it to be available for use within the next couple months.
Dr. Jordan, I know that you answered. I think you answered this question in the presentation. I was very intrigued about the relationship that you've developed with the breast surgeons, which sounds like this is a total win for everybody: patient, provider, referring physician, everybody involved in it. The question came in: Do you perform stereotactic guided biopsies? And obviously you do there. So can you need to expand on that a little bit?
Yes, we do. We actually, our clinic, again, just logistically, our clinic does not have a standalone stereotactic unit, nor do we have an add-on unit at any of the clinics. Our hospital facility, our local hospital facility, supports the stereotactic unit, and we refer both to ourselves inside our practice, CRR, and also to surgeons for the stereotactic unit at the hospital.
How many total mammograms are performed daily at all the sites? I mean, what's your kind of total volume? You have that off the top of your head? I hate to put you on the spot.
I do. No, I do. I'm thinking through. We have a couple of hospital. We have hospital facilities where we have not yet synced them with Intelerad. I read 120 across our facilities, our outpatient facilities. The hospitals themselves perform another probably 80.
Okay. And can you give us some sense of the level of support staff? We've had a question come in about the type and how many support staff do you have? Well, let's say per breast imager.
I can't overstate the importance of having a knowledgeable extender. How helpful having I have a lovely, and if there's any way I could have replaced my own picture where I look like Elvira in the slideshow, if I could have replaced that picture where I look like Elvira with a lovely picture of Kelly Maudlin, who is our navigator. I'm not even sure if she's listening, but in fact, I bet she's not. I bet she's running the clinic right now. But I'm shouting out to Kelly and Kelly's family members if anyone is listening. She does a terrific job. She's a part-time nurse, so there's she's a full-time nurse, but she works part-time for us, and that has even been a smart financial decision, as many of you know, in an HR component, and she does a terrific job. So I think the physician extender component of this cannot be overstated. Kelly functions, that's the private practice version of how breast clinics are run in academics. Remember, in academics you have an attending and 14 trainees, one of which I was, but in private practice you have 4 attendings and 14 trainees, and you're able to pull off that 100 patients a day, right? Well, in private practice, you have one breast imager, a part-time navigator, and 120 patients a day. It's just the reality of practice in action.
So you had better keep the passion alive for what it is you do, because I'm equally intrigued, and I don't think that we should be glossing over the fact that you've positioned the practice as a clinic, and I think that as the ACR and others who have really discussed radiologists being at the forefront of primary care medicine and really, in essence, transforming themselves and reinventing themselves to be integrally involved, visible within the healthcare communities, visible with patients, all those kind of things, which obviously you're doing. I think it's a great testimony to how you've managed to position the practice and gain market share for it. So, one of the questions that comes up is that in that regard, do you have does this your system replace the need or the requirement for a mammography reporting system of any other kind? I mean, is this fully integrated to the point where you don't need other kinds of reporting systems?
Jonathan may be able to answer that better. My sense is that it does. My sense is that the combination of Intelerad data points and the RIS data points are all that we need for our MQSA requirements. We do conduct audits. We do conduct the medical audits, and again, I think we're probably veering more into breast imagers and clinic questions, and I'm delighted that people are even asking these questions because that shows that we've got a listenership that are engaged and involved. It might be, I mean, it's a whole other topic of discussion, the use of data mining and medical audit. It's a whole other discussion, but it is absolutely coming. And we hope to be I believe, the cutting edge of it. We're not on the bleeding edge. You know, the data, that's the beauty of it all, Curtis, it's just data. I mean, you can't, there's no real need to massage it. Your recall rate is what it is. You know, right. So you just report it. It's not punitive at this point. It's not even particularly directive, or it doesn't have to be for practices. We've embraced it and elected to help it shape how we run our clinic, i.e. the work RVUs, and what we hope to achieve. We've also used it as individual physician modifiers, behavior modifiers. Me myself, actually, you know. So.
Do you have structured reports in other specialties?
We do. Yes, we absolutely do. We have them in all specialties to varying degrees. Breast is the leader. The ACR made it easy for us with BIRADS, but MSK has them. Ultrasound. Again, for the RCM participants, we all know how difficult it is to get an ultrasound reimbursed, both with regard to the ICD-9 as well as all the body parts that need to be included before you get credit for saying this lady's abdomen is completely normal. So ultrasound and MSK are close behind breast with regard to their value to the practice. But I only work inside macros. I actually toggle between modalities and toggle between sites, and do not limit the scope of my practice to only breast imaging. And I find the structure reporting extremely helpful. I work only inside the templates now. Intelerad just made it easy.
Is it possible, in that case, to dictate a section from scratch if you desired, rather than quote unquote under the edit?
Sure. That's an individual physician preference, and I have partners who absolutely are dictating from scratch. I'll editorialize that their work RVUs daily are considerably lower than mine. But you know, what are you going to say? What are you going to do? What are you going to do? We're all old dogs. Some of us learn our new tricks faster.
And what about the quality of the voice recognition? I mean, compared. I mean, obviously you shopped around, you compared. You know, how would you characterize the quality of the voice recognition piece?
Good, yeah. Very good. I won't say that I actually shopped around and compared. I would say, I'd turn it around, Curtis, and say I've lived it. I mean, literally 30 operating systems between the, I'm of the old, wet reading really was wet, that's how old I am, and 0 mammograms. I read 0 mammograms, or at least I saw them as comparisons when I started. And so since transitioning to digital, I've been on 30 different operating systems. If you add the PACS platform to the different transcription modules, and Intelerad is toward the top, if not at the top of VR, certainly at the top of all the other considerations.
Got time for two more questions. I got two that I think we'll wrap it up nicely. Just if you have it, can you share the callback rate? Do you have that?
The recall rate.
Yeah.
Oh yeah. I'm working so diligently to keep us under 10%, but we're not there. We're just not there. We're not there as an aggregate. So I work very diligently and try to get my numbers down because I'm a big denominator. But we're working very hard to be inside ACR medical audit numbers on all parameters, and so it's not unusual. It's not unusual for us to report a month where we're at 11 or 12% for digital. again, that is what it is, and it's there are different radiologists who feel differently about it. You know, some radiologists are much more in tune to their sensitivity than their specificity. I'm a specificity person, which means I'll be the first to acknowledge that there are a few small, slow-growing malignancies that are evident on the prior film, but that's where our recall rate is, hovering around 10%, some months more and some months less.
And final question, do you give the results directly to patients at all?
Absolutely. Absolutely.
And is it by phone, in person, or how do you?
Oh, no, I'm sitting right across from them.
You're sitting, okay,
yeah,
great.
I'm patting their hand, patting their knee.
Perfect.
This is what happens with our, and I'll finish with this. This is, I mean, people can start falling off as they need to. These are important questions, Curtis, and I think they need to be asked at least to answer the breast imagers that are on the line. In terms of, these are the questions that, behind structured reporting, these are the questions that come up in the ACR talks that I give. The navigator communicates on the diagnostic, for the diagnostic part of the clinic, the navigator communicates the BI-RADS 2 and some of the BI-RADS 3, because some of the BI-RADS 3 are just surveillance things, and the ladies are perfectly happy to hear from Kelly. And interestingly, it's been a little hump to get over. In the very beginning, when we started telling you that the doctor was going to come and speak to you, they were just, they just hated to see me. They were scared out of their mind to even get a normal report. So that's how we actually have evolved to the system that we have evolved, where a navigator functions as a resident or a fellow. It does in academics. But the BI-RADS 4, the BI-RADS 5, and the BI-RADS 6 are communicated directly from me to the patient in kind, compassionate, as I say in some of my reports, gentle manner, and to their family members. The thing about giving bad news about breast cancer is the news really isn't that bad, and the news, because of survival statistics, if you don't tell these ladies, they often leave with only the worst case scenario, and even worse than that, higher fear and anxiety than the reality, even in the worst of circumstances, is going to turn out to be for these ladies. And so it's been embraced. There's only a couple of referring physicians who prefer that we not talk to their patients, or prefer that Kelly not talk to their patients. And we are happy to oblige. It's how we've built the clinics.
Well, thank you so much. One of the listeners had asked if there'd be copies available of everything, and yes, including the macros that you provided here, correct? These slides are a part of our follow-up presentation.
Right now, I don't think there's no intention, right, to have all 28. Oh yeah, I would encourage everyone to start working inside them. The ACR embraces them.
Yeah, very good.
Yeah.
Dr. Jordan, thank you so much on behalf of Imaging Biz, Radiology Business Journal, and Intelerad, our sponsor, and you at CRR. We thank you very much for taking the time. We are going to sign off now, and again, everybody, this will be available online at imagingbiz.com and at Intelerad website as well. Thank you very much. We're going to log off now.
Thank you all.
Thank you, ladies and gentlemen. This concludes today's webcast. Thank you for participating. You may now disconnect.